Good evening, everyone, and welcome to the Society of Surgery for the Alimentary Tract's annual webinar on high-yield topics for the ABSITE 2021. My name is Zhi Ven Fong, and I'll be moderating today's session. This webinar is not meant to be your only source. It's more of a quick recap of high-yield topics for the ABSITE, just 2 weeks ahead of the exam. Throughout this webinar, please ask questions through our Q&A feature at the bottom of the screen, and we'll do our best to get to all of it. Before diving into the webinar, a quick introduction to our society for those who aren't members yet. SSAT, which is the Society for Surgery of the Alimentary Tract, was founded 60 years ago. While it was initially geared for colon surgery, it has now evolved to include all of GI surgery, including HPB surgery. It's one of my favorite societies because of the opportunity to learn and collaborate from not just surgeons, but gastroenterologists and hepatologists as well in our joint annual meeting, the Digestive Disease Week. Most of our audience today are candidate members, so it only costs you $20 a year to be a member. But that's very well worth it because you get access to our journal, the Journal of GI Surgery. There are plenty of scholarship and funding opportunities as well, on top of networking opportunities to get involved with the society's committees, even as a trainee. As previously mentioned, our annual meeting, Digestive Disease Week, will be held virtually in May, and I look forward to seeing you there. And you can visit our Resident Corner website for more great contents, including the recording of this video and ssat.com/residents. So without further ado, let's kick off the session with our first speaker, Dr. Yewande Alimi from Stanford University. Dr. Alimi will help us recap MIS and Bariatrics for the purpose of the ABSITE. Dr. Alimi, the floor is yours.
Thank you so much, Dr. Fong, and thank you for inviting me here today. Just going to put up my slides for everyone. As Dr. Fong mentioned, the focus of today is really to just hit the high yield topics and the highlights, as many of you are already sort of well into your studying for the ABSITE. Just a few sort of additional pointers to throw in here and just to plug a lot of what you're doing right now. If you're an intern, you've never taken the ABSITE before, just go back to your basics in terms of study prep. Everybody studies differently. This is not the time to sort of pick up a new routine to start learning how to study. Sort of go back and focus on what you've done in the past, and it will generally treat you well. And in addition to sort of this crunch time now, whatever happens at ABSITE this year is ABSITE this year, but for next year, know that, studying throughout the year, trying to do a little bit along the way is really gonna get you up and running for the rest of the year. So we're gonna focus today on MIS Bariatrics. And as previously stated, I'm Yewande Alimi. I'm currently an MIS Bariatric Fellow at Stanford University. I did my residency training at Georgetown in DC. Today, we're just going to focus mostly on laparoscopic technique and tenets, and then the bulk of the lecture will be on bariatric surgery, things highlighted on ABSITE in prior years, the common procedures that we do, and the complications associated with them. So for abdominal access can be in multiple ways in general for laparoscopy, an open or a Hassan approach versus a varus needle versus the optical trocar. The overall incidence of vascular bowel injury with the varus needle or trocar is 0.1%, and this is something to keep in mind. In regards to open Hassan, avoid blind insertion of the trocar or the needle. It's optimal in a patient who has significant prior abdominal surgery because this is direct access and entry. You can see the layers of the abdominal wall. You can watch out for bowel. You're going to do a finger sweep. You're going to make an incision. The fascia will be exposed. You'll incise the fascia. You'll put some stay sutures in, and a couple of different surgeons do this differently, but the tenets includes stay sutures that are placed on either side of the fascia. And after you get the preperitoneal fat sucked away and the underlying peritoneum is opened, this can be done by using a tonsil to grab it or whatnot, and then doing a finger sweep and placing in your Hassan. The varus needle is also an additional approach to gaining access into the abdomen. This is a blind entry of a blunt needle that has pressure deployed sharp needles, and you feel multiple points of resistance. This is in general to the fascia and the peritoneum, and you confirm placement by aspirating, instilling saline, and looking at a drop test. A good, nice flow on the drop test, and watching the insufflator show what the intra-abdominal pressure is. In general, a pressure less than 10 millimeters of mercury can confirm that you're in the right place. Can be higher in patients with increased intra-abdominal pressure, but don't be fixed on the fact that you're expecting this to be higher, so make sure you're really cautious when you're doing this. Optical entry is another route, and it allows for visualization of the layers as you go into the wall. In general, this is done with the 0-degree scope, so not a 30 or a 45, with an optical entry trocar, and then use the Varus needle prior to decrease injury to viscera. So you can use the Varus needle to establish some pneumoperitoneum, and then you can use optical entry going into your incision while you watch the layers and you enter into a dark space. So pneumoperitoneum, the normal pressures to establish are between 10 to 15. There are multiple cardiopulmonary effects of pneumoperitoneum. There's a great highlight of this in the Pfizer ABSITE book. But one thing to note is that bradycardia that happens following insufflation is usually due to the rate of insufflation rather than a high pressure. So it's because you have increased flow going in all at once versus just the fact that you are at an elevated pressure. So a way to reduce this is to start at a low flow state as you're increasing your insufflation for surgery. So the tenets of prior abdominal with patients with prior abdominal surgery, avoid entry at prior surgical scars. You know, if you're planning to do a lysis of adhesions with a diagnostic laparoscopy, totally fine, something that we do all the time, but make sure that you're placing your first port, not somewhere that you see ready scars, because you can anticipate in that patient that there may be some intra-abdominal adhesions in that area. And then in patients also where, you know, you sort of don't know what you're getting yourself into, the safest approach is always an open approach with the Hassan technique. The right upper quadrant or left upper quadrant lateral to the rectus muscle is usually the safest area to sort of get into the abdomen when you're doing any sort of optical entry or the varus, because you are avoiding the epigastric vessels and there's thicker abdominal wall in that area. And you can watch those layers, particularly with the optical trocar. So now let's focus on bariatric surgery. Bariatric surgery and the operations associated with it tends to show up on the ABSITE every year in some way, shape, or form. So focusing on the indications for bariatric surgery, you know, the NIH criteria for metabolic surgery include a BMI greater than 40 or a BMI of greater than 35 with coexisting obesity related conditions. So patients can have other conditions, but they need to be related to obesity, meaning obstructive sleep apnea, type 2 diabetics, coronary artery disease, in combination with this lower BMI. There are other NIH classifications, but those are not more readily tested. And then these patients had to have failed some sort of non-surgical method of weight loss before and have psychologic stability and be absent for drug and alcohol use. Different programs have sort of different rules as to how long they want this abstinence for, but all 4 of these criteria are required in order to qualify for a bariatric surgery. The different types of bariatric surgery can fall into several categories: restrictive procedures versus metabolic procedures, and then some combination procedures. We'll talk about all those here today. Restrictive procedures, the first I'll mention is a pretty historical procedure at this point in time. You know, it's not readily performed, and it's probably at about 3% compared to 5 years ago, which was at about 35.4%. And this is largely due to the increased complication rates. At the time that it was instituted, people felt like it was a pretty low risk procedure. It was reversible. It was the least invasive at the time, and it didn't have any effects on malabsorption, so there were no nutritional deficits, and there's a lower risk of death. However, over time, you know, there's up to 40% risk of complications, which is why this has really fallen out of favor. Those complications include erosion, esophageal dilation, breakage of the band, port issues, slippage, and failures of weight loss. And then in general, lower average weight loss compared to the other restrictive and then malabsorptive procedures that we have. The tenets of the operation include putting a silastic band into the abdomen around the stomach, as well as a surface port that is gained access and instills fluid to cause the increase in the band around the stomach. This port the fluid can be taken in, out, and out of the port to create more restriction of the gastric band. An x-ray can be done to sort of visualize the band, and you can see here the angle of the band. This is in general best to be between 4 and 48 degrees. And when you have a more flattened band, that's when you are concerned that there's been slippage. And we'll talk about this a little bit about this later. The other more common restrictive procedure, and to date is the procedure that we do most often is 58.1% is the sleeve gastrectomy. Many surgery residents know this procedure. It's about a 2/3 reduction of the stomach. A sleeve is created over a calibration device. The calibration device can be an endoscope or a bougie, whatever is the surgeon's preference. The average excess weight loss that's expected is about 50%, though this ranges in multiple studies. And then, excuse me, the resolution of comorbidities tends to be inferior to the Roux-en-Y gastric bypass, and these also include ranges. The important thing to think about with the sleeve gastrectomy is that it can increase the risk of worsening reflux, and so it's often not recommended in those patients. And then in patients who have pretty significant type 2 diabetes, at times patients are often veered in the direction of a Roux-en-Y gastric bypass. So the Roux-en-Y gastric bypass is sort of the steadfast operation previously of bariatric surgery. It's now the second most common procedure that we do, about 18 to 20%. The excess body weight loss expected, though, is about 70% for a patient in a pretty overall safe procedure. All of the bariatric surgeries we're talking about today, in general, the risks associated with them are on the order of between 2 to 5%. And so it's pretty low, and we're doing a better job at managing these patients. However, there's always associated complications, specifically with the Roux-en-Y gastric bypass, the concern for leak, internal hernias, with any morbid obese patient and a surgery, the risk of pulmonary embolus, marginal ulceration, and then the risk factors associated with that you're often quizzed on or pimped on are smoking as well as drug use. And then nutritional deficiencies, because this is also, in addition to being a restrictive procedure, is a malabsorptive one. And then the rates of resolution of comorbidities also range, but in general, patients type 2 diabetes and hypertension get better. And this is a good operation to help people who have reflux. And so this is where we first go with our patients who have reflux. There's an additional malabsorptive procedure, the duodenal switch. It's not often tested on the exam. So my slides do include a highlight on the duodenal switch, and you can check that on the website, but I won't go over it here today. The thing that you get mostly tested about the bariatric procedures include the fact that there are nutritional deficiencies, but also some of their complications. So specifically for a gastric band, the thing that you'll get tested about, or a picture that you might see, is a slipped band. And so we talked about earlier the feet angle for the band. Essentially, you want to see a sort of oblique angle of the band, and that's the band sitting around on the esophagus. You don't want the stomach to have around the stomach. You don't want the stomach to have slipped up and around it and sort of flattened out. And that's what you can see here, that it's a more horizontal picture. And so patients can present in that situation with PO intolerance and can have really significant problems with being able to tolerate food. The first thing to do for these patients is to reduce fluid out of the band by accessing the port with a Huber needle. Additionally, another thing that's often tested on the ABSITE is a patient who presents with the port site infection after a lap band. And that patient, the first thing that you want to think about, you can have port site infections in general, but the first thing you want to think about is an infection tracking from an erosion of a gastric band. And so that's sort of a harbinger for lap band erosion if you see something with port site infection. The additional complications for a sleeve gastrectomy that you want to think about are specifically leak. You have a high pressure system within the sleeve gastrectomy after you take away a significant portion of the stomach. And so in this high pressure system, you can have an increased risk of reflux associated in that situation, but also your leak rate at the staple line. If the person presents, less than post-op day 7 after an operation with significant abdominal pain, leukocytosis, and the general things that you look at for sepsis, you want to return to the operating room. In that situation, you try to wash out and repair what you can, plus or minus a stent. And in patients who present with late sleeve leaks, you want to go ahead and stent that patient plus or minus drain placement. I apologize for the typo, but this is not a sleeve type of vegetable, but a sleeve leak. And then the biggest other complication that we tend to talk about during morbid obesity surgeries are internal hernias. Internal hernias occur after we do any sort of rearrangement of the bowel or any resection because there's a defect within the mesentery. This defect within the mesentery allows bowel to slip into those areas. And because of the way that we form anastomoses, whether or not we create a gastrojejunostomy that is anticolic or retrocolic, we can create additional spaces within the abdomen that the pesky bowel can get into. And so the way to think about this is when you're creating your new connections during the Roux-en-Y gastric bypass, where are there potentials for bowel to sort of slip into place? The three areas that can happen is at the mesenteric defect at the jejunostomy. And this is one that's pretty obvious for people because in a majority of times that we see that we do this operation, this is the one that we always fix. This is the one that this is a type of defect that we fix in just general small bowel procedures. You know, when you put your limbs together, you're going to close that mesenteric defect. So this is one that I think is pretty intuitive for most people. The one that you know, people don't always remember, but is behind the roux limb mesentery, placed in a retrocolic or anticolic position when you're making your gastrojejunostomy. So this region is called Peterson's defect specifically, and bowel can slip in between the mesentery of the transverse colon and the mesentery of the small bowel that you're bringing up to create your candy cane limb, whether or not this is in front of the colon or behind the colon, and this is Peterson's defect. And then in patients who have a retrocolic formation of their Roux-en-Y gastrobypass, they can also have a defect at the level of the defect within the transverse colon for which you have passed the roux limb to create that GJ anastomosis in the retrocolic fashion. This is often is one of those other opportunities for the test to throw you a picture on the screen where you can see a swirling of the mesentery and a narrowing of the proximal SMV branches, as well as you can see sort of edematous bowel and mesenteric edema in the proximal jejunum. And then usually in these situations, not that this would be something that you would always be able to catch at first glance. I think the thing that will pop up on a test is a mesenteric swirl for you guys, but the small bowel tends to generally be in the left hemiabdomen in these situations. So these are the major complications that we see after bariatric surgery. An additional one that's not really often tested on though is intussusception, which happens to occur more often in patients who have had sort of rearrangement of anatomy, which is a phenomenon that's described, but not something that's often tested, but something that you might be pimped on when you're on a bariatric service. So those are the highlights of MIS and bariatric surgery. And I thank the SSAT for giving me the opportunity to help you guys prepare for this test. And I see there are a couple of questions. Yes, so for William Wong, the top image that's abnormal for the slip band is that it's completely horizontal in that image. So you can see here that it's completely flattened as opposed to being at a more oblique angle. Thank you.
Thank you, Dr. Alimi. That was a fantastic overview. And I think from a format perspective, what we can do is that don't worry about responding to the Q&A while you're talking. We can move on to the next speaker, and when you're done talking, we'll have the experts respond to the Q&A. So for our next speaker, we'll move on to our next topic. Dr. Helen Johnson is from East Carolina University, and she'll be talking to us about breasts for the ABSITE. Dr. Johnson?
Oh, thanks so much for having me. All right, just to share where I have the majority of this information from, I based most of this on NCCN guidelines and then also used SCORE questions to see what the latest is because breast care management has evolved over, well, it's always rapidly evolving, but it's evolved over the past 10, 15 years particularly. And so there's a lot of questions every year about, is this going to be on the test? And while I can't say exactly because I'm not writing the test, I can base it off of SCORE as my best approximation. So the main thing to know for breast cancer screening is that guidelines differ by society, but focusing on NCCN, the recommendation is annual mammography starting at age 40 for average risk women. And for higher risk women, for higher risk women, NCCN recommends using MRI as a supplemental screening modality, and this generally starts around age 25. There's specific criteria in one of their guidelines, but these main ones are at least a 20% lifetime risk of breast cancer, a known deleterious mutation such as BRCA or other genetic diseases, a first-degree relative with one of the above, or a history of kind of mantle-type chest radiation at a young age, such as 10 to 30 years old. All right, focusing specifically on BRCA. So these individuals with a deleterious BRCA mutation have a higher lifetime risk of breast cancer than an average individual, as well as an increased risk of ovarian cancer. When I have percentages shown out for the BRCA1 versus BRCA2 mutations, one takeaway is that the risk of ovarian cancer is higher in BRCA1 mutation carriers. BRCA2 is associated with male breast cancer, prostate, and pancreatic cancer as well. So these patients have specific screening, which is different for women and men. For women, you have an annual clinical breast exam starting at age 25, and for men, this starts at 35. And screening for women begins with just an MRI from ages 25 to 29, and then once you reach age 30, you start with the mammography with or without the supplemental screening modality of MRI for the high-risk women. Men, you can consider an annual mammogram starting at age 50 or 10 years before the youngest family member was diagnosed with male breast cancer. And just don't forget about the other things that you have to worry about in these patients, such as prostate cancer screening for the BRCA2 male carriers starting at age 40. And something to think about for these patients would be risk-reducing surgery with bilateral mastectomies, as well as bilateral salpingo-oophorectomies for genetically female individuals. So this can be after the completion of childbearing or between ages 35 to 40 for the BRCA1 carriers because their risk is higher, or ages 40 to 45 for the BRCA2 carriers. All right, so that's for screening. Now moving on to diagnostic breast imaging. If you have any abnormalities on your screening mammogram, your next step will be to order diagnostic imaging, which is generally a diagnostic mammogram, which can have additional magnification views, plus or minus an ultrasound, depending on the situation. So kind of differentiating between breast complaints and breast masses. Breast complaints are things like pain or discharge. If the patient comes to you with those complaints and they are due for screening, you should at the very least do that. And then depending on your clinical exam, you might need to do diagnostic imaging. Breast masses should basically always be evaluated with diagnostic imaging. And women below 30, you need to use an ultrasound because their breasts tend to be more dense, and mammography is not generally as helpful as it is in women whose breasts are less dense. 30 and up, you do a mammogram as well as an ultrasound. If you're pregnant or breastfeeding, then an ultrasound is the first line for that patient. Mammogram versus ultrasound, so why use one or the other or both? So a mammogram can show you calcifications, which an ultrasound cannot, particularly fine calcifications. Other findings you can see on a mammogram would be asymmetry and architectural distortion. And then an MRI may be beneficial for patients with very, very dense breast tissue, but I think for ABSITE purposes, we'll mostly be seeing that for questions about a cold breast cancer. Some examples of suspicious findings on mammography would be pleomorphic calcifications, so they have different sizes and shapes and appearances. Linear calcifications is kind of suggestive of DCIS. If you see linear pleomorphic fine calcifications, think DCIS in the question stem. A spiculated mass is obviously going to be concerning for malignancy. On ultrasound, because they might just describe the findings and not say, this is a, BI-RADS 5 or something. They might say, on ultrasound, there's a hypoechoic mass with irregular borders and posterior shadowing. That's describing something that's solid, that's not a simple cyst. That would be suspicious. And then just a quick word about cysts. There's a lot of benign breast cysts out there that are going to be seen on ultrasounds, and you do not have to aspirate them if they're not symptomatic and they don't have any concerning features. But if they have anything that is non-simple, like a BI-RADS score of 3 or more, which I'll get to in a second, Those should be aspirated. And then if the fluid is bloody, send for cytology. If it comes back, that's an indication for biopsy. Pretty much in real life and for the ABSITE, a core needle biopsy is going to be superior to a fine needle aspiration because you can get tissue architecture as well as knowing whether you just have an abnormal or normal cell. And if you can only see the abnormality on mammogram, you're going to have to do a stereotactic biopsy, whereas if you can see it on other imaging modalities like ultrasound or MRI, you can use those modalities to localize the lesion for biopsy. A big thing that I've seen a lot of questions about is kind of describing a very concerning history and exam and then giving the diagnostic breast imaging with a biopsy that says benign breast tissue or, you know, some kind of mild inflammation. And that's a situation where the exam and the biopsy are discordant. And in those situations, you need to do a surgical excisional biopsy to really get an idea of what's happening in the breast. So I've seen multiple questions, and I think that is a good likelihood type of question to see. So the BI-RADS scoring system is used for diagnostic imaging, and it's from 0 to 6, and it's quite similar to the thyroid, the TI-RADS scale to have some overlap with your studying. So 0 means we don't have enough information, we need to get more imaging. 6 means we already know this patient has cancer and we are looking for something else, but they have cancer, everybody knows that. 1 is a completely normal exam. There's no findings whatsoever, and that patient would fall back into routine screening. Anything else means we do have a finding, and it's a scale of how likely is it to be malignant. So a BI-RADS 2 is we saw something and it is definitely benign. This is a simple benign cyst. This is nothing to worry about. That's a routine screening patient. A 3 is there's something, and I'm pretty sure that it's benign, but I'm not 100% sure. It might be something like a fibroadenoma that has a very characteristic appearance. Let's repeat the imaging every 6 months for 2 years to ensure stability. And if at any point that were to change, then that would be an indication for a biopsy. A BI-RADS 4, this gets further broken down into ABC, which may be beyond the scope of the ABSITE. But these are suspicious findings and warrant a biopsy. And 5 is quite suspicious and absolutely needs a biopsy. All right, then moving on to specific breast complaints or breast pathologies, starting with nipple discharge. Nipple discharge in general is more likely to be benign than malignant, but the risk of malignancy does increase with age. And the most common pathology is an intraductal papilloma, which generally presents with bloody nipple discharge. Features that are concerning for malignancy are bloody discharge or serous discharge, not physiologic discharge, which can be really almost any color, but is generally described as kind of yellow or greenish in tinge. Unilateral is more concerning than bilateral, and a single duct is more concerning than multiple ducts, particularly if it's spontaneous and persistent. For the workup, you're going to order diagnostic breast imaging, which depends on the age of the patient, but generally will include a mammogram and an ultrasound. If you still can't find a lesion that may be explaining this pathologic nipple discharge, you might progress to an MRI. If you find anything on these, that's your target for biopsy. If you still haven't found a lesion, you can try ductography. And if all imaging fails to localize a lesion or there's anything that's discordant, then you perform a duct excision, which will generally be a terminal duct excision if it's a single duct that you can cannulate and identify, or if it's multiple ducts and it's a concerning situation, then you do a central duct excision of all of the ducts. Fibroepithelial lesions are a spectrum of tumors ranging from benign fibroadenomas to up to phylloides tumors. So these usually present as a rubbery mobile mass, and these are hormone sensitive, so they can enlarge during pregnancy and they tend to involute after menopause. Because they are mass, you proceed with diagnostic imaging with an ultrasound and possibly a mammogram, depending on the patient's age. So if it is consistent with a fibroadenoma, it's a rubbery mass, it looks just like a fibroadenoma on imaging, you can follow these with serial imaging as a BI-RADS 3 lesion to ensure that it's stable. If it is growing or changes in any way, then an excision is recommended. Some people do recommend a triple concordance with a biopsy up front to prove it, but I've seen questions on ABSITE that are okay following these with serial imaging. Phylloides tumors can be benign, borderline, or malignant. They may describe it and describe both epithelial and stromal components with maybe vimentin and actin on the stains. And the treatment for these is a wide local excision with 1 centimeter gross margins for the ABSITE, not necessarily in real life. And on the ABSITE, and definitely in real life, if you have a positive margin, you need to re-excise to negative pathologic margins. These kind of behave like sarcomas and spread hematogenously, so you do not need to do a sentinel lymph node biopsy for these. When you biopsy these, if your core shows a kind of a cellular or indeterminate fibroadenoma, it's impossible really to distinguish this from a phylloides tumor. So a cellular fibroadenoma is kind of the exception for fibroadenomas that definitely need to be excised, not just those that are changing and enlarging. All right, risk lesions. There's a lot of words out there and it can get confusing, but basically anything that has the word atypia in it needs an excisional biopsy. So examples of this would be atypical ductal hyperplasia, atypical papilloma. The American Society of Breast Surgeons does not recommend routine excision of atypical lobular hyperplasia, so that's slightly controversial, but I doubt they'd put that on the ABSITE, but if they did, I would err on the side of doing an excisional biopsy of that as well. These are all lesions that suggest that you are at an above average risk of breast cancer, and there could be a malignancy harbored within the tissue surrounding whatever was biopsied that showed atypical risk lesions. So that's why you need to do the excisional biopsy to rule out an invasive cancer. If there is no invasive cancer, these patients may benefit from kind of chemoprevention strategies such as tamoxifen to decrease their risk of breast cancer during their lifetime. Another risk lesion that's kind of its own entity is a radial scar. This also needs an excisional biopsy to exclude malignancy. Sometimes they'll throw out other terms for this to make it confusing, or they'll only describe it. So if you see anything that's describing like a radial type lesion that has a fibroelastic core, or a stellate lesion with a fibroelastic core, that is describing a radial scar on imaging. Other terms include those listed there, and note that it is not sclerosing adenosis because that can get confusing. So atypia and radial scar, excisional biopsy. DCIS is considered to be a non-obligate precursor of invasive cancer. About 25% of these lesions do harbor an invasive cancer, and at the time of surgical excision, you will get an upgrade. The consensus guidelines state that you need at least 2 millimeter margins when you excise DCIS. So if you get a question where the patient has DCIS and you have a close margin of less than 2 millimeters, the answer is going to be to go back for re-excision of that particular margin, or if you didn't take representative margins and mark your lumpectomy cavity, then you're going to have to excise all of the margins to get all of the margins to get to your at least 2 millimeter negative pathologic margin. Most of these patients are treated with breast conservation therapy, which is defined as lumpectomy with radiation therapy. And I've seen questions asking specifically the role of radiation, which is that it decreases the risk of recurrence of both DCIS and invasive cancer. Some DCIS will warrant mastectomy if it's very large or it's multicentric, which means multiple quadrants, not to be confused with, I'm sorry, I'm blanking on the term, multifocal disease. So multicentric, multiple centers, multiple quadrants. On the ABSITE, sometimes I've seen questions asking about cometonecrosis, which I think in Pfizer, it says cometonecrosis is it suggests it's an absolute indication for mastectomy, which is not in practice the case, but it is a factor to consider. It is not an absolute, so I would consider that for the current ABSITE based on more recent score questions. And a mastectomy is also indicated in DCIS if there's a contraindication to radiation therapy. Don't forget, if you're doing a mastectomy, you do a sentinel lymph node biopsy because you are concerned about a risk of upgrade to invasive cancer, and you don't want to burn your bridge if you do a mastectomy, if you do need to go back and do a sentinel lymph node. After your breast conservation therapy, these patients are candidates for adjuvant endocrine therapy if they are ER or PR positive. And they may ask a question about the current COMET trial, which is comparing active surveillance versus standard therapy for low-grade DCIS. So for women without cometonecrosis, without multicentric disease, just very low-grade bland DCIS, The COMET trial is looking at monitoring them with serial imaging and not excising them. LCIS is different. So this is a marker for an increased risk of cancer, which is about on the order of 1% per year. And this cancer can occur anywhere in either breast. The tricky thing is, while these women are at a bit increased risk for a lobular cancer, the most common type of malignancy that they do develop is a ductal carcinoma. These patients warrant risk reduction strategies like endocrine therapy with tamoxifen or prophylactic mastectomy. So usually you see this on a biopsy for something else. You don't normally, have a solid mass and biopsy it and it's LCIS. Usually there's no mammographic findings. You may see a description of the staining, and a kind of key term is a loss of expression of E-cadherin. Routine excisional biopsy is controversial because it can occur anywhere the invasive disease can occur anywhere in the breast. So if you do perform an excisional biopsy, for classic LCIS, there's no goal for negative margins. You're just ruling out any invasive cancer that's being harbored in that general vicinity. Pleomorphic LCIS is the exception, kind of like the cellular fibroadenoma was the exception. So pleomorphic LCIS behaves similarly to DCIS. You need to excise to negative margins. All right, and then moving on to invasive breast cancer. So there are complicated staging schema for all the cancers. You don't have to get too in the weeds about it. I would just be aware that there are multiple staging schema for breast cancer, including anatomic stage and then clinical stage and pathologic stage. And that one thing that's pretty different about breast now compared to a lot of other cancers is that it's not just your typical tumor node metastasis stage. They've also added biomarkers like grade, estrogen receptor status, progesterone receptor, and HER2. I think most of the staging questions I've seen on ABSITE have to do with the anatomic or pathologic stage. So looking at anatomic stage, a T1 lesion is up to 2 centimeters, T2 is 2 to 5, T3 is greater than 5, and T4 invades the skin or the chest wall, which is not the pec major. And then something I've also seen asked is a description of an inflammatory breast cancer, which is a T4D. Sometimes people get confused and think it's a stage 4, but it is a T4. And then end stage, N1 would be 1 to 3 positive axillary nodes, N2, 4 to 9, or an isolated internal mammary, and 3 would be 10 or more axillary nodes, or some nodes near the clavicle or internal mammary, as well as others. For axillary anatomy, you have levels 1, 2, and 3 axillary lymph nodes. Levels 1 and 2 are the standard for a complete axillary lymph node dissection for breast cancer, where you add the third for something like melanoma. So level 1 are the nodes lateral to the pec minor, level 2 are deep to the pec minor, and level 3 are medial to the pec minor. There's a whole host of important nerves, and just for time's sake, I'm going to let people read these in the slides. This is something that you just have to memorize, which nerve does what and what happens if you injure it. And I have some things in bold to help remember. So the treatment of breast cancer is complex, and it is individualized to the specific patient and is done in a multidisciplinary fashion. So it is quite challenging to make big generalizations, but I think that's going to be the types of questions you will get on ABSITE based on past years and current score questions. So I've broken this into kind of early stage versus late stage breast cancer. So some examples of early stage breast cancer are going to be somewhere in the lower T's, so T1, 2, or 3, and these are N0, so clinically negative nodes. These patients generally are treated with surgery first. There's questions asking about breast conservation therapy versus mastectomy. And don't forget, breast conservation therapy means a lumpectomy, but also radiation therapy. These have equivalent survival. If you look at some data, it suggests that breast conservation has a slightly higher risk of recurrence. Kind of longer term data has shown that this is maybe not quite as high as was anticipated previously, but I think on the ABSITE, the answer is still that breast conservation therapy has a slightly higher risk of recurrence, but survival is equivalent. So contraindications to breast conservation therapy would be if the patient's not interested in it, if she or he is not a candidate for radiation therapy. So this includes first and second trimester of pregnancy. If they're in the third trimester of pregnancy, you can wait and have a short interval of time until after delivery to do postpartum radiation therapy. So that would be acceptable. Prior chest radiation is a relative contraindication. If they've already been treated for breast cancer on that side and it's quite remote, depending on the fields, they may be able to do it. And something that seems to be the most common question is active connective tissue disease. So this is going to be something big like scleroderma or lupus. Other contraindications would be diffuse multicentric disease that's really not amenable, a very large tumor, such as greater than 5 centimeters, like a T3, depending on the tumor to breast ratio. These need to be excised to a negative margin, which for invasive breast cancer means no ink on tumor, which is distinct from DCIS. If you have a positive margin, this needs a re-excision. And you have to do axillary staging with a sentinel lymph node biopsy. The recommendation would be for dual tracer, meaning a vital blue dye and a radiocolloid. If you've had a sentinel lymph node biopsy before, it is still possible to do one again and you attempt the tracing. If you are unable to map the sentinel lymph node with both of these tracers, then you perform an axillary lymph node dissection, which, as I said, for breast is levels 1 and 2. A note on the Z11 trial, which is, I think, getting more commonly tested now. This trial looked at adult women with small tumors, so T1 and 2, with clinically negative nodes who were treated with breast conservation therapy, including sentinel lymph node biopsy. Those who had a low nodal burden, so 1 or 2 positive sentinel nodes, were randomized to no further axillary surgery, but completion of their breast conservation therapy, which includes the radiation, versus axillary dissection. And they have similar local recurrence and survival. So they may ask a question about a woman or man that meets Z11 criteria. They may not say the word Z11, but they'll describe a early stage breast cancer with clinically negative nodes, that is a patient's undergoing breast conservation. They only have 1 or 2 positive sentinel nodes. What's your next step? And the question is, do you have to go back for an axillary dissection? And the answer is no, if they meet Z11 criteria. They do need to get the radiation therapy. So for locally advanced breast cancer, these would be things like something with clinically positive nodes and very large T stages, or something like inflammatory breast cancer. Most of these patients were treated with neoadjuvant chemotherapy. Sometimes they were treated with surgery first, and this is where a lot of the art and individualization of breast cancer care comes into play. A note about the special case of inflammatory breast cancer. This is a clinical diagnosis. So you need erythema, edema, and pogerange of more than 1/3 of the breast. You can establish the diagnosis with a skin punch biopsy with the pathognomonic finding of dermal lymphatic invasion, which is not required for diagnosis. If your punch biopsy is negative and you're pretty clinically suspicious, if there are palpable nodes, those are good targets to do another biopsy. And these are always treated the same. So neoadjuvant chemotherapy, modified radical mastectomy, which means a total mastectomy with an axillary lymph node dissection. All these patients get post-mastectomy radiation, and then if they qualify based on their ER status, endocrine therapy. I've seen some questions where they will say the patient was treated with neoadjuvant chemo and they had a complete clinical response. There's nothing else on imaging. Do they really need the modified radical mastectomy? And the answer is yes. At this time, that is the standard of care. Modified radical mastectomy and post-mastectomy radiation will follow for all these patients. All right, a word about chemotherapy. So who gets chemotherapy? Obviously, if they present with distant metastatic disease, they warrant chemotherapy, like the M1 patients. Positive nodes, triple negative, meaning ER negative, PR negative, HER2 negative patients are all indicated for chemotherapy. HER2 positive patients get anti-HER2 targeted therapies, which are generally given with systemic chemotherapy. So those patients are also generally candidates for chemotherapy. And then for the other category, which is not triple negative and not HER2 positive, would be an ER positive, HER2 negative patient. So according to NCCN, if it's greater than 0.5 centimeter with pathologically negative nodes, what you're supposed to do is a genomic risk score, which the one validated in NCCN is a 21 gene assay, like Oncotype DX. And you base your decision about chemotherapy on their recurrence risk. So if they have a high score, which is 31 or greater, chemotherapy is indicated. And then there's kind of a gray area for 26 to 30 range. There's a lot of studies going on right now, and this is getting parsed out more and more, but I think for the ABSITE, this is the safe information to know. For patients that meet criteria for chemotherapy, like a triple negative breast cancer, is it better to do neoadjuvant or adjuvant? Well, the long-term survival and recurrence is similar, but the rates of breast conservation are higher for the neoadjuvant treatment. So that would be the answer on the ABSITE, the main advantage. And then I've just listed some of the common regimens for chemotherapy and their major side effects. And these are other things to just memorize for the test. Radiation therapy, don't forget, is for local regional control of the disease and is an essential part of breast conservation therapy. Radiation therapy can be omitted in older women greater than 70 with ER positive, very small tumors T1 and 0, provided that they do endocrine therapy. For post-mastectomy radiation, what are the indications? Well, we already discussed inflammatory breast cancer, and then big tumors, so T3 or greater, which is greater than 5 centimeters. Positive margins that can't be re-excised or a very, very close margin. And then 4 or more lymph nodes. And in some cases, you want to consider for any positive lymph nodes. Endocrine therapy, I've mentioned several times, if patients have ER positive disease, they're candidates for endocrine therapy, but what does that mean? So in general, the agent used for premenopausal women is tamoxifen, but don't forget about the risk of uterine cancer and DVT-PEs with this. And generally, postmenopausal women are offered aromatase inhibitors, and there's a whole host of names, and the treatment duration is at least 5 years. For patients with HER2 positive disease, they are eligible for anti-HER2 targeted therapy, which is with trastuzumab, also known as Herceptin, and then pertuzumab. And as I mentioned, this is generally given in combination with cytotoxic chemotherapy. All right, a word about male breast cancer. We said earlier that a risk factor would be a deleterious BRCA2 mutation. Another would be Klinefelter's. These are generally treated quite similar to breast cancer in women, but breast conservation is not generally offered, and chemotherapy indications begin at greater than 0.5 centimeters. And if the man does meet criteria for adjuvant endocrine therapy, tamoxifen is the agent because there's limited data on aromatase inhibitors. For pregnancy-associated breast cancer, we mentioned that radiation is contraindicated in trimesters 1 and 2, so these are generally treated with a mastectomy if they are getting surgery during their pregnancy. However, it's okay to wait to do postpartum radiation therapy for some patients that are being treated in their 3rd trimester, depending on the time interval. A lot of these patients are treated neoadjuvantly with chemotherapy. However, that cannot be given in the 1st trimester, and you have to hold it for a few weeks before delivery. If you are performing a sentinel lymph node biopsy, blue dye is contraindicated. So blue dye crosses the placenta and is, I remember, blue, bad for babies. Paget's disease is kind of an eczematous change of the nipple areolar complex, and this is a good one for pictures. And this is a marker of underlying either DCIS or invasive disease and needs imaging workup. So diagnostic imaging is indicated in these patients as well as a skin punch biopsy. The skin punch will show large cells with pale cytoplasm and prominent nucleoli. The treatment for this is going to be on the ABSITE, at least a central partial mastectomy. You need to remove the nipple areolar complex. On the ABSITE, they tend to describe a lot of these situations, and the answer is often a total mastectomy just because of the extent of disease. And then just kind of a potpourri of benign things. So Mondor's disease is just a fancy name for superficial thrombophlebitis. This is idiopathic. It just happens suddenly, and the age range tends to be 30 to 60-year-olds. So that every question I've seen has had that exact patient. The treatment is NSAIDs and warm compresses, as for other thrombophlebitis. Lactational mastitis questions, the answers are always basically focusing on continuing to breastfeed. You need to continue to drain the breast just like you would if you had a kidney stone. You need to flush the system, or a UTI, keep peeing. So keep draining the breast. Treatment for breast abscesses is going to be aspiration as your first line, and sometimes serial aspirations are required. And then the next best thing is percutaneous drainage, and these are all superior to the big old-fashioned surgical IND hacks that we used to make. The most common organism is Staph aureus. I've seen questions that you're treating a patient for an abscess, or particularly a lactational abscess, and they're not getting better. What do? You need to switch your antibiotics to cover for MRSA. hopefully you'll have your culture results to guide that at that time anyhow. IgM, idiopathic granulomatous mastitis. This is basically Crohn's disease of the breast. There's granulomas, there's fistulae, there's abscesses. It's horrible. And just like with Crohn's, you avoid operating as much as possible unless you're forced to. This requires this whole big workup. The one thing they might ask you is to rule out TB. Periductal mastitis is going to be subareolar abscesses that happen over and over and over again in smokers, and the treatment is smoking cessation. Try also not to operate on these, but they're not as horrible looking as IgM. Galactorrhea presentation, the workup is going to be to check medications which may be causing galactorrhea, especially medications that may alter prolactin levels like psychiatric medications, and then do a pregnancy test and check thyroid hormone and prolactin. If they do have a high prolactin, then go on to look for a pituitary lesion with an MRI. Breast implant-associated anaplastic large cell lymphoma. This can happen years after a patient has had textured implants placed and presents generally with a fluid collection with or without overlying erythema. You need to aspirate the fluid and send for cytology and pathology. This has become kind of a sexy topic lately, so I've seen more and more questions over the last year or so. Gynecomastia, you need to differentiate from pseudogynecomastia, which is kind of the medical nice way of saying you just have excess fat in that area. So gynecomastia is actual breast tissue, not just excess adipose tissue. And it is painful and will have generally a subareolar mass. For this, you need to, kind of similar to galactorrhea, check meds, check labs, and don't forget about checking LH and testosterone and estrogen with these. And I'm happy to take questions. I'll take a look at the Q&A.
Thanks, Dr. Johnson, for the great review. I think you've covered a lot of ground and you've simplified a very complex topic and really contextualized the topic in the context of the ABSITE for all of us. So while Dr. Johnson's going to address the question in the Q&A, we're going to move on to our final topic. Dr. Andrea Gillis is from Albany Medical Center, and she'll be reviewing head and neck, thyroid, and parathyroid. Dr. Gillis.
Hello. Okay, can you see the slides?
We can, you're perfect.
Thank you.
Looks good.
All right, so hi, my name is Andrea Gillis. So these topics are not the most high yield, but you will definitely get some questions on endocrine and head and neck. So I put up the breakdown of what I'm going to talk about here. So we're going to start with head and neck. What does a general surgeon need to know that's relevant for the ABSITE? So you may get presented with a neck mass, and really location, location, location is key. So you need to know each of these neck triangles and what is contained therein. So it's sort of self-explanatory. Submandibular triangle, you can expect just some shoddy lymph nodes. Carotid triangle, obviously the carotid and internal jugular are going to be there. So when they present a patient, they're going to give you the landmarks and you have to understand exactly where they're describing. And then you go, they'll usually give you the history and exam, and they'll give you some buzzwords that sort of give you a clue to what treatment pathway they're asking for. So infectious etiologies of neck masses, you're going to hear things like travel, dental work. These are more likely to seed somewhere in the head and neck with an infection. Sometimes we'll get the elderly patient with poor dentition or secretion control, and that you're thinking of sialinitis, which can happen postoperatively. Or in a child, these are usually cervical lymphadenopathy, can be infectious. Usually they're going to give you obvious indications that it's an infection, so erythema, pain. Clinically, you can treat these with antibiotics, and if they don't improve, then your suspicion is raised for one of the other two categories. So neoplasm, these are often in patients with obvious risk factors, so heavy alcohol, heavy tobacco, or previous malignancy, usually in the head and neck region, like thyroid or oral cancers, which we'll talk about in a second. These lymph nodes, if it's going more immunosuppression lymphoma route, they're usually fixed, immobile. You can get some B symptoms, fevers, chills at night. Usually you can start with an ultrasound, which they'll usually give you one or the other option, ultrasound or CT neck. Biopsy these if it's an obvious mass, or if it's a lymph node, these should be approached with an excisional biopsy, meaning you take the entire lymph node. And then congenital, pretty rare, but you may see a question about this. It's going to be one of these cysts, cystic hygromas, usually diagnosed preoperative or prenatally. All of these need to be resected due to their infectious risk down the line. And then the unique resection for a thyroglossal duct cyst is a cyst trunk procedure where you resect the cyst and the midline hyoid bone. So moving on to head and neck cancer, something that we do not see a lot of, but I think as a general surgeon, you should have some idea of the types of procedures that may be done and the types of complications you may see afterwards. So risk factors are the same as I mentioned before. If there's an unknown primary, there's an extensive workup that you can do in order to find out where the mass came from. And usually it's going to be a squamous cell cancer. So that includes a bronchoscopy, laryngoscopy, EGD, in order to try to find where exactly the cancer is coming from. And this can even include tonsillectomy or random biopsies at the base of the tongue. And then salivary gland tumors, rarely seen, but often tested. The most common cause of a tumor in the parotid gland is going to be actually a skin cancer. So think melanoma of the head and neck. But if you do get a primary salivary gland tumor, know that the facial nerve divides superficial and deep parotid. Usually if you have a tumor here, you don't need to biopsy it and you go straight to resection because of the risk of nerve damage. And then overall treatment for squamous cell cancer of the head and neck, very early stages can be resected. If it's pretty advanced, you're gonna think about definitive chemoradiation because these are very morbid surgeries. Distant mets need chemo. And then another question you might get is who needs a lymph node dissection, which is going to be a modified radical neck dissection in head and neck cancer. So anyone with obvious palpable positive lymph nodes are going to need a modified radical neck dissection in addition to the resection of the primary tumor. The salivary gland tumors, rarely you'll see a question about this, but just know the names benign, pleomorphic adenoma, and papillary cyst adenoma are the most common. The only interesting thing about the papillary cyst adenoma is that 10% are bilateral. The malignant salivary tumors, mucoepidermoid and adenoid cystic. Interesting thing about adenoid cystic, which is the rarest, is that they tend to have perineural spread, which means pain because the fascial nerve is involved. Benign salivary gland tumors can just have a superficial parotidectomy. If it's malignant, you need to take the total parotid and try to avoid taking the facial nerve unless it's grossly involved. And then the malignant ones need lymph node dissections. And then the laryngeal and mucosal malignancies, usually the only thing you need to think about is the airway. So if you're intubating these patients, say if a general surgeon has to do a PEG, know that these can be a difficult airway. So you need to have fiber optic available. If you're in a trauma bay, have anesthesia on standby. But I think those are the only things they might ask you about that. So modified radical neck dissection, who needs it and what is it? So these are the lymph node stations of the neck. Just remember, 1 is pretty high up above the hyoid bone, 2, 3, and 4 along the jugular chain, 5 is posterior neck, and 6 we only really care about in thyroid, but is sort of next to the thyroid, so anterior and posterior to the thyroid gland. Who needs it? All medullary thyroid cancers need at least a central neck or 6, and then any differentiated thyroid cancer with known preoperative positive mets to the lymph node will need that lymph node station resected. So it's either going to be 6 if the central node is positive, or all of 1 through 5 if the lateral neck is positive. Things they might ask you are what can be injured here? So on the left side, be wary of the thoracic duct and a thoracic duct leak postoperatively, know how to manage that. And on both sides, we have the spinal accessory nerve, phrenic nerve, brachial plexus, which you really should never see, but could potentially be injured in a modified radical neck dissection. And then central neck, in the center, these are the borders. So thyroid nodules, I think people tend to get overwhelmed with them, but if you break it down in a stepwise fashion, this is how they should all be approached. And really, we just care about who needs to be resected. So they'll give you the history and physical in the question stem. The next thing you need to do is test for functionality. So if you have a hyperfunctioning nodule, they're usually not clinically relevant because you find these incidentally. So they, by definition, have subclinical hyperthyroidism. The next thing you do on the test, not always in practice, is a radioisotope scan. So you need to see, is the functionality coming from the entire thyroid, or is it coming from this incidentally found thyroid nodule? If the entire thyroid is hot or active on radioisotope scan, and this one nodule is cold, that's on the test pathognomonic for malignancy, an increased risk for malignancy, then you can go forward with biopsying and monitoring this nodule. If the patient is normal thyroid or even has hypothyroidism or Hashimoto's, then it's pretty unheard of for this incidental nodule to be cancerous, but you do still want to follow it, so you proceed with ultrasound and biopsy if it meets criteria. So what are the criteria? Why do we biopsy these? It's to determine who needs to be resected. There's only 3 reasons to resect a thyroid nodule or thyroid gland. If the patient has symptoms, so compression or inflammatory symptoms such as pain. If the nodule is hyperfunctional, so like we mentioned, if you get the thyroid function test. And if there's concern for malignancy. So certain nodules are more suspicious for malignancy. So starting with the benign nodule, so if it's pure cyst, just like in breast, it's usually benign. If there's an intact rim or halo sign, it's usually benign. And if there's low vascularity, it's usually benign. So we have a lot more leeway to follow these if it looks very normal and benign. You really wouldn't biopsy these unless they're pretty large, 2 centimeters. Malignant features are basically the opposite of the benign. So not cystic, solid, lots of vascularity, microcalcifications, and a disrupted halo sign or interruption in that rim calcification. You biopsy these at smaller sizes because you're worried about them being cancer. So you can go back and look at this PDF a little bit more closely, but I got this from Savison. I think this is a really great chart to take a quick glance at before the test. Microcalcifications are very, very suspicious. Interrupted borders, very suspicious. And then these are the less suspicious things down below. So everyone's favorite, the Bethesda classification. Don't get overwhelmed by it. You only need to memorize the 3 in the middle. It's obvious what you're going to do if it's benign and malignant. So in the middle, if they give you undetermined significance, it means the pathologist really isn't sure. And honestly, these 3 in the middle, only 25% of all biopsies in real life will come back as this, but these are the easiest to test on because it's the decision tree branch. So undetermined significance, you want to repeat that biopsy, or if the patient is not adverse to surgery, they may just want to take it out, and that is the definitive biopsy. I think molecular testing is going to start showing up more on the exam. And really, this is just a test of the FNA specimen, testing for certain suspicious genes. So things like BRAF mutation, if you find that in an FNA, you're less likely to want to sit on that. And it can help you push towards doing a lobectomy. But it's never going to reassure you. Not having that mutation does not reassure you that it's for sure not cancer. So that's what they're going to ask you. The molecular testing says, no, it's not a malignant gene mutation. Do you still want to go forward with a lobectomy? You need to do something, either repeat the biopsy or go forward with a lobectomy. It only pushes you towards surgery. It never reassures you. So Bethesda 4, it has neoplasm in the name. So you know you need to do something more aggressive than just a repeat FNA. That means that there's as much as 30% chance of cancer. And the suspicious for malignancy, pretty much everyone would say go ahead and take that out. So what malignancy are we looking at? So just remember that there's only really 2 types of cells in the thyroid, the follicular unit, which makes thyroid globin and synthesizes thyroid hormone, and the parafollicular cells, which make calcitonin or C cells. So I think that's how sometimes people get confused at the difference between papillary and follicular. These are both from the follicular cells. The only way you know it's a follicular neoplasm is if you see vascular or capsular invasion, which you can't see on an FNA. So that's how we get this follicular neoplasm of undetermined significance, because they can't see the capsular invasion. You need a whole specimen to see that. Most common is papillary, so papillary is popular. I've never seen a pathology slide, so I didn't give any pictures, but they may describe small bodies or Fernandi nuclei, which are eccentric nuclei, and that's how they can tell it's papillary and not a follicular neoplasm. When you look at how these patients present, it's usually incidental. They've gotten an FNA and it's come back as cancer. Who needs a total or partial thyroidectomy? A common question. Total thyroidectomy is preferred if you know the patient is higher risk and they're going to need radioactive iodine postoperatively. So high risk, I'll go into in the next slide, but anything bigger than 1 centimeter is higher risk of recurrence. And anyone who has high risk features or positive lymph nodes. These people are most likely going to need radioactive iodine ablation in order to make sure they have long-term cancer-free survival. Everyone needs postoperative surveillance because even if you just do the lobe, there's a 20% risk that they will develop cancer on the other side. Both these are differentiated cancers, papillary and follicular, and both of these take up radioactive iodine and can be treated postoperatively with ablation. Follicular is unique in that it spreads hematogenously. So these are going to be the patients who you see bone mets after thyroid cancer, which is often pretty unusual. Note that medullary cancer, totally different cell type. These are the calcitonin producing C cells. They do not take up radioactive iodine, so you can't treat these postoperatively if you have some residual disease, which is why we're so much more aggressive with our initial upfront surgery. These are the patients who get a total thyroidectomy. There is no such thing as a lobectomy in medullary thyroid cancer. In addition, the most common place that the medullary thyroid cancer spreads is that level 6 central neck. So everyone with medullary thyroid cancer gets a prophylactic level 6 lymph node dissection. Only if you have positive nodes in the lateral neck do you go that far with the medullary with a modified radical neck dissection in medullary cancer. Or if you know the 6 is positive, they have a higher risk for having lateral neck nodes. So if the 6 level is positive, or if you have preoperative positive nodes in the lateral neck, you get the modified radical neck dissection for medullary. Postoperatively, you surveil these with calcitonin levels in the serum. If they start to increase, then you need aggressive ultrasound surveillance in order to find a residual focus of medullary cancer. And then anaplastic, we always think of as the very aggressive elderly patients. If it's caught early, or if it's found on a post-resection specimen, you need to go back and do a total thyroidectomy. Or if it's already so advanced, these are usually palliative tracheostomies, and the patients will not survive very long. So again, about the lymph nodes, any differentiated thyroid cancer, if you have it on FNA, if they ask you the next step, it's going to be the ultrasound, the central and lateral neck lymph nodes, because if it's positive, they need a neck dissection. What are you looking for on a positive lymph node? Enlarged, loss of fatty hilum. Here's some pictures. They may give you this in words. And medullary thyroid cancer preoperative workup must include a test for RET mutation or a pheochromocytoma evaluation, because the pheo will need to be resected before the thyroid cancer. And then just a brief word on prognosis. Age is the most important prognostic variable, which is a little unique to thyroid cancer. The lymph node positivity is an increased risk for recurrence, but not for long-term survival. Thyroid cancer is very slow growing, so even if it's made it to the lymph node, it's usually not made it much further than that. And then here I mentioned again, who needs RAI? So larger and more aggressive tumors. And you can't give RAI if you have residual thyroid, because that residual thyroid, even if it's benign, is just going to take up all the radioactive iodine, and it won't ablate the small metastatic disease, which is the whole point of the RAI, is to get rid of any distant mets or any residual mets in the thyroid bed. Extrathyroidal extension, positive lymph nodes, positive margins, all of these people will need RAI. So if you only did a lobe and any of this comes back, if it was a really large tumor, or if you have positive lymph nodes, you need to go back and take the other lobe or do a completion because they need the RAI. And this is sort of where this comes from. Why are these patients at a higher risk? Because this retrospective studies have shown that if they have any of these things, they're more likely to recur, including this variant. Brief word on thyroiditis. You may get a question about how to manage someone with hypothyroidism, and it's usually not surgery. It's usually treat them with thyroid hormone replacement. You only operate for those 3 reasons that I mentioned before: increased risk of cancer or compressive symptoms. And then the thyroiditis that are painful are either infectious, which is bacterial, treat that with antibiotics and abscess drainage if necessary. Painful subacute, which is Dacre veins, usually from an upper respiratory infection, so they do not need antibiotics. These are the people who have pain 6 weeks after a URI. You can't really do anything to treat it other than supportive care. And then Rydell's thyroiditis, which is the firm, fibrous thyroid. They're usually hypothyroid, and you can treat these with Synthroid, steroids, or tamoxifen. You only operate, again, for the above reason, compression or symptoms. Parathyroids, know the embryology of this. I've seen questions on this. The inferior parathyroid is from the 3rd pharyngeal pouch along with the thymus. and the superior parathyroid is from the pharyngeal pouch, the fourth pharyngeal pouch. So the third pouch has to migrate further. So the inferior parathyroids are a little more aberrant in their location sometimes. They're more likely to be missed or to be ectopic. Know the physiology of PTH. It increases calcium and decreases serum phosphorus. The location of the parathyroids, I kind of think of the parathyroid being leaned backwards, so the superior or posterior to the recurrent laryngeal nerve and lateral, and the inferior are anterior to the nerve and medial. And know that the inferior thyroid artery supplies all 4 glands. Hyperparathyroidism, mostly we'll see primary hyperparathyroidism. So if the PTH is elevated and the calcium is elevated, the PTH is inappropriately elevated for an elevated calcium. Usually you would expect this to be normalized because the parathyroids don't need to increase calcium any further. This is diagnostic for primary hyperparathyroidism. You can go ahead and do imaging studies to try to find the adenoma. Because it's the most common type of hyperparathyroidism. Now, if you have secondary hyperparathyroidism, that usually means there's a medical reason why the calcium isn't responding to the PTH elevation. So the parathyroids are actually normal. They're appropriately increasing secretion because the calcium levels are not elevated or are low because of vitamin D deficiency or CKD. This is not treated surgically because there's nothing wrong with the parathyroids. This is an appropriate response. Now, tertiary is after a long time of having this appropriate elevation of parathyroid, you can develop 4-gland hyperplasia. And after the patients have gotten a renal transplant or the medical reason why the calcium wasn't normal is resolved, the calcium is going to be appropriately elevated, but the parathyroid hormones are inappropriately still overreactive. This does need surgery because this isn't going to be treated medically. It's never going to go away. And then parathyroid carcinoma, very, very high level of calcium. If they give you a calcium above 14, be very suspicious. And that's treated with the parathyroidectomy and the ipsilateral thyroid lobectomy. If they give you low calcium in the urine, know that they're trying to trick you. You don't want to resect that. That means that they have familial benign hypocalciuric hypocalcemia. So if the parathyroid is overacting and the calcium sensing channels in the kidney are normal, you should have high calcium in the urine because you have high calcium in the serum. But if this isn't the case, then it's just a physiologic variant and resecting the parathyroids isn't going to cure them. What imaging needs to be done for hyperparathyroidism? Remember, only get imaging after you have a diagnosis. You never want to go looking for an adenoma if they don't have hyperparathyroidism. That's another trick. Who gets surgery? Most people are going to be asymptomatic, so you look at lab values and other clinical presentation changes for who to resect. So elevated calcium above normal level. This has been shown over long-term studies to have detrimental effects on patients' cardiovascular health and bone health. So if they have that, then that's a criteria to have surgery. If the kidneys are showing in-organ damage, so elevated or reduced creatinine clearance, kidney stones, or elevated urine calcium, that's an indication. Very young patients is a soft indication. And if they have bone disease, so osteoporosis or unusual fractures, such as in the long bones or distal radius, especially in younger patients, that's an indication. Most people will have a single adenoma, and that can be resected. If they have 4-gland hyperplasia, which you see more commonly in the MEN syndromes, they can have a 3.5-gland resection and an autotransplantation of that half gland. These are the MEN syndromes, which every year will show up. They'll ask you, what is the genetic abnormality? Or they'll ask you, what other thing do you need to look for? So if somebody has medullary thyroid cancer, like we mentioned, be very suspicious that they have a RET mutation, because 20% of medullary thyroid cancers do. And you need to make sure they don't have a pheochromocytoma before they undergo general anesthesia. Just a quick word about adrenal masses. You will get asked something about adrenal. Incidentalloma is the most common type of mass that we'll see. 60% of them are non-functioning. They have very characteristic imaging on contrasted CT, rapid enhancement, and rapid washout. That's pathognomonic for an adrenal benign adenoma. Know that there is no named adrenal artery. The blood supply is secondary from the inferior phrenic, aorta, and renal arteries. On the right, the named adrenal vein goes directly into the IVC, and on the left, it drains into the renal vein. And know how to work up an incidentaloma. So 4 hormones that you need to test for: hypercortisolism, hyperaldosteronism, pheochromocytoma, and very rarely the sex hormones, which is almost pathognomonic for cancer. Which adrenal masses need to be resected, if they're large, if they're functional, or if there's concern for cancer, very similar to thyroid. Thank you.
Thanks, Dr. Gillis, for the great overview. I'm going to share my screen real quick. So I want to be respectful of everyone's time, so we're going to end here. If anyone had any questions unanswered, or if you have any questions, please feel free to email any one of us. Everyone who registered will be emailed a link to the recording of this webinar in the next few days. And if you'd like to re-review the recaps, the videos are all on the link. Alternatively, the recordings and the slides from each presenter will also be posted on the SSAT website following the conclusion of the webinar. I want to thank our speakers, Dr. Alimi, Dr. Johnson, and Dr. Gillis. I'd also like to thank Dr. Maria Altieri and Dr. Motes Kedan, who are the chair-elect and chair of our SSAT Resident and Fellow Education Committee, for spearheading the webinars. And most importantly, L.K. Coughlin, our administrative director, who was instrumental in making all this happen behind the scenes. Good night, everyone, and good luck for the episode.
Good luck, everyone.